taught the sun where to stand in the morning? And who told the ocean you can only come this far? And who showed the moon where to hide till evening? Whose words alone can catch a falling star? Well, I know my Redeemer lives. I
thank you for taking part to our program, our health program, from this morning until this minute. We thank you for your time and thank you for staying back to assist the program. We would like to welcome you to the second part of the health program. Before we proceed with the presenters, I'm going to ask you to bow your head for prayer. God, we would like to thank you for your privilege that you've given to us. We are not worthy of serving, but you have given us the task to serve. We thank you. You have been with us in the first part of the program, and glory is to you and to your name because everything went well. At this minute, we are going to proceed with the second part. Please be with us like you did this morning. In Jesus' name we pray. Amen. I know you already know who we have today. We have Dr. Grace Levy-Clark, and we have Dr. Perez. So Dr. Grace, like we said earlier, is a medical graduate from the Medical College of Wisconsin. She completed her ophthalmology residency at Ohio State University. Then she proceeded to have a fellowship in immunology and ocular uveitis specialist at INH Institute, at the INH Eye Institute or Ophthalmology Institute. She's been working for about 27 years in that particular field, and her philosophy is to treat both body, mind, and spirit. And this is why she takes time with her patient to make sure none of this part is neglected. For a second time, we have with us Dr. Grace Levy-Clark.
Good afternoon, everyone, and welcome back. This afternoon, our theme is gastroenterology, or the gut, and I'm going to be talking to you about different types of eye diseases that are associated with diseases of the gut. And we'll go to our first slide. So there are a group of diseases that we're going to talk about, and the fancy medical term that we call them are spondyloarthropathies. These are diseases that can be associated with many different parts of the body. Specifically, these diseases can involve the gut or the GI tract, the joints, the skin, or the eyes. When we see these patients in the clinic, some of them may be associated with a special gene type. Now, this is not a genetic disorder, but this is a disorder that if you have a certain gene type, you will have a greater predilection or a greater chance of developing these diseases. And this genotype is called the HLA-B27, and this is a genotype that we can test you for in the clinic. The ones that I see that develop autoimmune eye disease or uveitis, there are 5 of them: Crohn's disease, ulcerative colitis, and Crohn's disease and ulcerative colitis we combine together and we call it inflammatory bowel disease. The second one is ankylosing spondylitis. And ankylosing spondylitis is a disease that affects any part of the spine from the neck all the way down to the tailbone. Many of the patients will present with arthritis along the spine. And then the fourth type is something called reactive arthritis. That is a type of arthritis that you get after you've had an infection somewhere. Typically, it could be a gastrointestinal infection, and after the infection, for some reason, you start to getting arthritis all over the body, and we'll talk some more about that. And then the final one is psoriasis. So for the gut, there are three main ones: Crohn's, ulcerative colitis, and reactive arthritis, which can develop after you've had gastroenteritis, which is an inflammatory disease of the gut caused by certain types of bacteria, or it could be also caused by an infectious form of genital infection. It's a genital urinary tract infection. And we call that one urethritis, and it would be more commonly in the men. And then finally, psoriasis, we know, is inflammation that can affect the skin. So let's talk about Crohn's disease first. So Crohn's disease is one of the inflammatory bowel disease. And this disease can present either first with the gastrointestinal symptoms, or it can present first with the arthritis, or it can present with the eye disease. So of course, many of the patients that I see are the ones who are mixed. They've either been diagnosed already with the Crohn's disease and they develop the eye disease, or they develop the eye disease and then we do some testing and we find out that they have Crohn's disease. Not everyone in this group of diseases will have the positive genotype, but it is one of the risk factors, but you don't have to test positive for it. Now, if we look at the eye is divided into what I like to call the three chambers. And I'll just use the cursor to see if you're able to see that. The front part of the eye is everything from the cornea, which is the very, very front part, all the way to the colored part of your eye, which we call the iris. And then when you go behind the lens, which is a part of the eye that can develop a cataract, what you have is a cavity. And this cavity is filled with a gel that we call vitreous. So that's the middle part of the eye. And then behind that cavity, you'll see that there's a layer that runs all the way across, and that's called the retina. And we call that part the back of the eye, or the posterior part of the eye. So when we talk about eye diseases, we usually describe it if it's affecting the front, the middle, or the back part of the eye. Why is this important? It's important because depending on where the problem is in your eyes, you're gonna present with a different type of symptom. So if it's happening in the front part of your eye, you're gonna have pain, and you're gonna have redness. So you're gonna wake up and be able to look at your eyes, it will look red. When we look at the eye, we will see other things. But typically, when I talk to patients about uveitis, these are the symptoms they usually have: redness, pain, light sensitivity, blurred vision, or floaters. So let's talk a little bit about the redness and the pain. This redness and the pain, and we'll show you some pictures of it first. So the anterior uveitis is the front part of the eye. And when we say red, we mean very red. But what you will notice, it is not a blood red. So if you wake up and you see redness that looks like blood, it's probably a broken blood vessel. But this is a redness that really truly looks more pink. So if you notice, the part of the eye that's red, you can see the white around it, right? Because what is red is actually just the blood vessels are engorged and they look more prominent. The reason why they are red is because that is how the body fights infection or inflammation. So my area of specialization is inflammation, but there are certain infections that can cause inflammation. So I do have a crossover. I do see patients who have certain types of infection, and we will do a different lecture focusing on that. But just so you know, there are certain types of infection that can cause uveitis also. But today, we're going to focus on the inflammatory diseases, and those are the diseases that are due to what we call an autoimmune reaction in your body. Now, what is that? That is when your body's immune system, instead of working for you, it's working what? Against you. And there are many types of autoimmune diseases. All of the ones that I mentioned before are examples. And they're particularly connected because some part of their presentation could be the gut or the eyes. But they do all seem to have some form of arthritis also. This arthritis is not the type that you get because of your age. So it's not osteoarthritis. It's an inflammatory arthritis. When you look at the picture of this eye, you also see that there is an area where there's a whiteness showing inside the eye. Now, this is a part we hope that nobody's easily disturbed, but that is actually like pus in the eye. That is a collection of white blood cells. So when you go to the eye doctor and you sit at the slit lamp, what we can see is a magnification of your eyes. When we look into the eyes, it should be a clear fluid in the front. And that clear fluid is called aqueous. When you have an inflammation, and again, it would look the same if you had a bad infection. That is why it's important to get your eyes examined by a professional. If you look at it, a red eye can be like 10 different things. In this specific case, when we look into the eye, what we will see are actually white blood cells that are moving around. And if they collect in the eye, that is what that white layer is. So it's a layer of white blood cells. That is the body trying to work to improve the situation, but painful for you. The redness, we say, are the engorged vessels. When we look at the eye, we can also see some other things. And when I put the picture together, my granddaughter was able to say immediately, that's not a normal pupil. See how irregular it looks? She said, why does it look like that? It looks like that because when you have inflammation in your eye, the blood vessels are leaking out fibrin, which tends to be a sticky substance. And the iris, which is a color part of your eye, starts to stick to the back of it of the anterior chamber, which is the front of your lens. And when it sticks, it scars on. And your pupil is not going to be normal again. You're going to have that regular pupil. And we call those areas of posterior synechia. It's just a fancy word for an attachment. It's a kind of a fibrous tissue, and it just sticks on there. There are other things we can look at the slit lamp. If you look at this eye, what you see is some small white dots. These white dots are the actual white blood cells, and they're the ones that join together to form that layer that you were seeing before. So at the start of the inflammation, when we come into the office, we can look and we can see all these things that we call signs. So in medicine, anything you feel is called a symptom, and anything we can see is called a sign. So I usually talk about the signs and the symptoms of a disease. So these are all the signs: the redness, the pain, the light sensitivity, the floaters, the blurry vision would be the symptoms. If you look at this picture, what you see is, you see a rim of brown tissue. So this is what happens if your iris gets stuck. Remember we showed that before? We can give you a dilating drop that pulls the fibrous tissue apart. But even though your pupil becomes round again, you're permanently going to have brown fibrous tissue. Surprisingly, though, your vision will be fine. You won't notice it. And there are patients who will come in and say, I've never had uveitis, but I can look at the eye and say, you have, because that scarring is not going to go away. But it doesn't affect your vision, because you know why? You're looking right through the center of it. Your central vision is very center. That is why you can see, even when a lot of things are going on, that center, the dead center is clear. You are able to see right through it. So let's go back and talk a little bit more about Crohn's disease and ulcerative colitis. So our gastroenterologist is going to come later. So I will give you just a few of the tidbits from that area. The signs that you would have, or the symptoms, would be you'd start having diarrhea. But it's a specific type of diarrhea. It is what we refer to as bloody diarrhea. And that is because you have areas of inflammation inside your gut, right? In the intestines. And so those areas, when they're inflamed, it's like sores. You develop, that's why they call it ulcerative colitis. You actually have ulcers in your colon, okay? And so people will develop these bloody diarrhea, but you can become very sick to the point where you're just not able to eat. And some of these patients actually have to have parts of their intestines removed because the inflammation won't go away. It's the only way they can feel better. They remove it, sew the intestines back together, and now they're able to skip that part basically. Or if you're not a surgical candidate, you have to go on medication for a lifetime, because those sores will go and come. And when they come, you're going to be very sick. So you take the medicine to keep yourself even all the way through. And that is really important. When we talk about ankylosing spondylitis, that is the one where you will develop inflammation along the spine. And many of those patients will complain of neck pain, or they will complain of lower back pain. The neck pain can be severe, and in the old days before we had appropriate therapy, those areas will become fused together, and those patients would not be, they would have no mobility in their neck. So they would just be stuck in this position, curved down. The back would be also so severely inflamed that those patients would either start walking with a walker or going to a wheelchair. And those are patients who are young. So many of the patients that I see with autoimmune diseases, 20 through 40. And unfortunately, even very young babies can develop early autoimmune diseases. I've seen Crohn's disease in patients as young as 12, and it's very severe. What we're going to do is we're going to switch over and move now more towards the gastroenterology, and we're gonna continue the eye discussions afterwards. But I'll give you a few tidbits in the meantime, and that is autoimmune diseases can be very subtle. They can be difficult to diagnose, and you can be sick for a long time before it's recognized. It is important that if you start to have symptoms, you bring that to your primary care physician, and then they can always refer you. Many times what I see in the eye area, patients will go for a long time, keep getting new glasses. I say my advice to you is, if you're having pain, redness, and light sensitivity, and you get to see someone and they tell you you need new glasses, you maybe should get a second opinion because you probably have something more going on than just the need for new glasses. And what I hope to do is continue to discuss with you more what are some of the signs and symptoms for the different types of eye diseases. Thank you.
Well done. All right. We ask that you write your question down, or if you can remember the question, try to remember it, because after the next presentation, we're going to take question either for Dr. Clark or Dr. Perez. Now, ladies and gentlemen, it is my privilege to introduce to you Dr. Roger or Rogelio Perez. He's a gastroenterologist by training. Dr. Perez completed his medical school degree at the Johns Hopkins University Medical School. So he graduated the top 18% of his class that time. He proceeded to complete his internal medicine residency at the Mass General Hospital, that Massachusetts General Hospital. So he completed his internal medicine training there. he continued to complete his fellowship in gastroenterology at the Mayo Clinic. So from that time, he has been working for more than 20 years, treating a number of gastrointestinal tract disease. So he moved from New Haven, Connecticut, to us here in St. Petersburg. He's now working with a group called Florida Gastroenterology. So now you have been in good hands since this morning, and you stay in good hand with Dr. Rogelio Perez. Help me welcome, ladies and gentlemen, Dr. Rogelio Perez.
Thank you so much. Thanks. I can't enough say the last talk was really good, and it's I'm glad I actually need to get your card because I really have a lot of patients. I tell patients all the time when I see patients with stomach issues that there's a stomach and eye connection, and a lot of people don't realize it. So patients that I have that Crohn's disease or people who have autoimmune illnesses, other illnesses, I tell them that they can have eye, and I tell them the same thing. I tell them they need to see sometimes, they see an optometrist and they don't see an ophthalmologist, and I tell them, you know, if you see the optometrist, they may miss it if they don't know that you could have inflammation in your eye. And I tell them if they have problems with their eyes, they should call me so I can refer them to somebody who's a specialist in eye problems and you can really lose your vision or have problems and you need certain types of medications, steroid drops or other medications that are pretty strong to really reverse the inflammation in the eye. So no, 100%, I think it's actually not that many people know about it and not that many doctors treat it, so it's actually quite good. So I'm going to talk just a little bit about something a little bit more mundane, more a little basic, but colon cancer. I just want to talk about colon cancer. So colon cancer, let's see, this is to advance? Okay. So I think a lot of people have been talking about colon cancer lately, and I kind of just want to go through things because there's a lot of things, some new things, but also things that I think people have misconceptions, things that people think they know about colon cancer or rumors, and it's not true. So the first thing is, it's interesting is that the lowest rates of colon cancer is in Africa and South Central Asia. So that's the lowest rate. That's where the lowest. The highest rates are in Europe, North America, here, Australia. And if you look at the percentage of people in the U.S., it's about 4% have colon cancer, but it's 20% higher in Black Americans than in white Americans. So that's important. I think people didn't realize that for the longest time. And I'll mention this in a minute, but even the age has changed about when you're supposed to have your colonoscopy and be evaluated. In Black Americans, it was 45 earlier than it was in the rest of the country. But a lot of people didn't think, we thought it was 50 in everybody. But it was actually 45 in people who were Black Americans. It's been like that for like over 10 years that you're supposed to do it when you're 45. But people just weren't doing it. They would wait till they're 50. So again, and there's also a shift when I say that there's a shift towards people having colon cancer on the right side of the colon. So if you think of the colon, this is the right side of your colon. The middle, the transverse, and this is the left side. In the old days, years ago, a long time ago, 40 years ago, they used to do the tests in the office where people used to just do a flexible sigmoidoscopy where we do it in the office and people would, didn't have to go through a colonoscopy. They would just look inside, but we would only see this part of the colon. We'd only see the left part of the colon. And what was happening is we were missing all the colon cancers that were on this side of the colon. And we used to think, well, it happens primarily here. And what was happening is that we started seeing people showing up later in years with the colon cancer over here because it shows up sooner on this side. People will have bleeding or they'll have more diarrhea or they'll have other symptoms sooner. When colon cancer starts in this part of the colon, on the right side, you don't feel it until it's really late. You don't really feel it at all. Many times people show up with colon cancer and they don't have any symptoms at all. The only thing that they have is anemia. They're just anemic. So if somebody has anemia that's brand new, and we don't have a good reason why they're anemic, right? And if it happens to you, that's why we tell people you have to make sure that you don't have colon cancer in this part of your colon. And so many people show up they feel fine, they just feel tired or weak or whatever. It's because they're anemic, and it's because they're losing blood from a spot over here, and they have no other symptoms. So there's a shift towards us seeing colon cancer more on the right side. Part of that's because we were always only checking people on the left before. Now that's why we do full colonoscopies, because we want to make sure we're not missing it in different parts. We're noticing that we are seeing it more over here too, partly because we realize that people are just not doing the preparations are good, and it's really important. Can't lay people, it's really important that you do your preps the best you can. So sometimes, and we know patients say, I only drank, well, I couldn't drink it anymore. I just stopped, and they only drink half of it, right? Or they, or they stop halfway, or then they kind of lie to us and say, well, I did it, I drank it all. And then, we say, no, but you really have to be clean. You can't just be sort of clean. We look in there, and we can tell if you're not telling the truth, because we see that it's still in there. It's not cleaned out, right? And then you end up having to either come back again. But more importantly, not just about coming back, is that that's how we miss colon cancers, right? Because when it's dirty, we can't see, right? And this is the part of the colon that we can't see the best. I tell people, when you do the preparation, the colon prep, we usually do it now, we split it. So we do part the night before and part the morning of the test, right? And that's changed. That wasn't like that up until maybe 5 years ago or so. Before, it was always just the night before, and I used to do it at the night before just to make it more convenient for the patients. But now we do it because we realize when you drink the first prep at night, it cleans out this part of the colon. When you drink the second part the next morning, it cleans out this part of the colon, right? So if you don't do both, we don't see the polyps over here, we don't see the colon cancer over here, and we miss things, right? So that's how sometimes we're finding is that we will do a colonoscopy and we think it's clear, but if the person wasn't cleaned out, there's a chance that we could miss up to 10 to 15% of polyps or colon cancer in this side of the colon if you're just not cleaned out. So I can tell you it's really important, right, to try to, and honestly, there's a lot better preparations out there. The old-fashioned, the big gallon jug that everybody talks about having to drink that, there's actually different ones. I don't use that one ever anymore. I haven't used the big gallon jug in probably over 10 years, okay? So there's a lot other ones that are much smaller that are only 11 ounces. There's other ones that are just, a few different bottles, so it's much easier. So if you go to your doctor and they say they're going to give you the gallon jug, you can ask, there's other choices. There's other things they can do, okay? The other thing is we're noticing, though, and this is just more of for intellectual interest, is that we're starting to know that there's actually a different type of cancer that shows up in this part of the colon, that the polyps that grow on this side are different than the polyps that grow on this side. And the polyps that grow on this side, we used to think those wouldn't become cancerous, some of the kind. These serrated adenomas are different types of polyps, and those we never thought used to become cancer. Now we realize they do become cancer, and we need to remove those. And if we remove the polyps, it decreases your risk back to the baseline population. So if we remove 4 polyps in you, then your risk becomes like somebody who doesn't have polyps. All right, let me just go to the next slide. Sorry. Oh. Not sure if I'm doing this right, sorry. Somehow it's not advancing.
I try to just advance it from the computer.
Oh, from the computer?
That's what I do.
Okay.
Just hit the enter button.
Oh, there we go. I'm sorry. Thank you very much. Thanks. So the other thing I guess I want to point out is that the mortality from colon cancer has gone down. Right? So it really has gone down. It's because now we're starting to do screening more, we're really testing people more, and it really has made a huge difference. But I'm going to point out a few things. So the mortality has gone down, right? What's happening now is that now we're starting to see it in younger people because older people are getting their colonoscopies. A lot more people who are 60s and 70s are getting their colonoscopies, but the people who are young, because when you're 40, you think you're healthy, you don't need to have anything done, right? And so now we're seeing that people that are younger in their earlier ages, I'm seeing many 40-year-olds who have colon cancer, either in their mid to early 40s. It's surprising. So I try to encourage people, if they have, even if somebody in the family has colon cancer, if kids or siblings or things, to get other family members tested, even if they're only 40 sometimes, because they're at risk sometimes. Okay, so we're seeing that that it's declined actually significantly, but not in younger people. So from 2000 to 2004, there was an increase. It was a 1% increase. But now we're actually seeing it's actually starting to go up again. From 2018 to now, it's actually gone up about 1%, 1 to 2%. But it's what we've seen it now. It's going up in whites and Hispanic individuals. Right? So let me just go to the next slide. So in particular, what I wanted to show you here is this is the rate of colon cancer in people at different age groups, right? So you can see, sure, it's pretty low. It's at age 35 to 39, it's only 10, but by the time you go up another 5 years, it goes from 10 to 20. Like literally, it doubles right there, right? I mean, that's pretty impressive. And by the time you get to 45, it goes up to 30. So it's 3 times more common, but here, and that's why before we would do it at 50, it's 60, right? 60, and then it just keeps going up more and more, okay? And the thing I want to point out also about this, I think it's important, and I'm going to mention this to you. It's a little, no, I wouldn't say it's controversial. I think it's common sense, but I want to tell people about it and throw it out there. So you can see here's 70 to 74. 75 to 79, it goes up to 197. By the time you're 80, it goes up 237, right? And it's going up quite a bit, right? So I think, many times people will say, well, they told me I don't have to have it done anymore because I'm 75, right? Right. So, and they say that all the time. And I know patients say that to me. They told me not to do it anymore. And I mean, I'll be honest, many people, they want to hear they don't want to have to do a colonoscopy. They'd rather hear I can get out of it, right? So, but the reality is I see many people who are 80, 78, 82, 82 is not that old anymore, right? I mean, that's not, I don't think of 82 as being old, honestly. So I see a lot of 82-year-olds, they're doing everything. They're doing everything better than 62-year-olds. So it's really all based on how healthy you are, right? I tell people, honestly, if you're healthy and you're 80, you should do the colonoscopy, right? If you're 60 and you're not healthy and you've had a heart attack and you've had a stroke and you've had dialysis and all these things, then maybe you shouldn't do it, right? Because it might put you at risk, right? And I'm not saying you shouldn't do a colonoscopy. What I'm saying is it depends on how healthy you are. So so I've seen many people who I've diagnosed into their mid to late 80s who told me I would have come back and done the colonoscopy. They told me to stop coming back. So I stopped. And then I do a colonoscopy when they're 85, 87, 88. I diagnose their colon cancer and have to send them to have part of their colon removed. And I say, how does that make any sense? I'm going to send somebody who's 85 to have part of their colon removed, but I won't do a colonoscopy on somebody who's 80 years old. That doesn't make any sense, right? So what I'm saying is that I think it's something that you should all think about. Just because you're a certain age doesn't mean you shouldn't do it. It means, depends on how healthy you are, you feel like you're still doing well and still functioning and you're still doing things, then I think you should think about it, okay? And you should bring it up to your doctors too, okay? So in the GI world, gastroenterologists, we tell people all the time, it really depends. We don't just stop doing it at a certain age because you're a certain age. Again, you can see it all depends on your age. Once you get to a certain age, it really starts to take off. And that's how we first decided at age 50. We really first decided it was partly because of insurance companies. That's really why it's done at age 50. Because that's where the insurance companies started saying, okay, now it's cost effective. It's worth it to us to put you to a colonoscopy because we'll pay for it because it's going to, but if it's too early, then they don't want to do it because it's going to cost them too much money. So even changing from age 50 to 45, which happened, just a couple years ago, for about 10 years, gastroenterologists have been arguing about should we do it at 45 or 50. And it was partly because they were saying the cost of having to do it in 45-year-olds, the extra 5 years, so many more people are going to have it done that we're going to spend so much more money. And it was all based on that's a big part of why people didn't want to do it at age 45, just because of the cost. So, and obviously I don't think that's a good reason. That's just now we're not. So the incidence, as I mentioned, the rate in the country was declining by 2% per year, and it slowed down to 1.2%. But that's because it was going down in older people. Again, older people were getting their colonoscopies. But the rate in these countries that I said was low, like Asia, Eastern Asia, Europe, Spain, things like that, it used to be low, but it's going up rapidly in those countries. Right? And again, it's really, I want you to hear in people who are under age 50, under age 65, it increased from 11% to 20% from 1995 to 2019, right? I mean, it almost doubled, right? So I think it's, we're starting to notice it in younger people, as I said. And over 86% of patients that are diagnosed with colon cancer are asymptomatic. Their symptoms, they don't have symptoms until much later, right? So that's the problem, is that people that are young don't show up until really late, until they're already having bleeding, they're having pain, they're having diarrhea. And because they show up so late, the chances of them getting cured is lower, okay? So the later you wait, the worse the outcome, right? It's just, that's what it is. So about the people that are younger, about 35% of them have it because of hereditary reasons, okay? And I think that's an important thing that I kind of like to point out to patients in general, because people think, I don't have a family history, so why do I need to have this test done, right? So a lot of people think, I don't have a family history, but only 15% of people who have colon cancer have a family history of colon cancer, okay? So people that have colon cancer, the other 85% of people, they didn't have any family history of colon cancer, okay? So that's important because I think, many of us think, well, I don't have anybody in my family with colon cancer, so I'm not going to get colon cancer, right? So that's a misconception. The other misconception, some people think it happens to men and not women. And that's just not true, right? That it happens to, it happens more in men than women. And it happens equally in men and women. It doesn't make a difference, okay? Let me just go on a little bit. I don't want to focus. All this really shows is that when on people who are in this part of the colon, like I said, in this part, because they don't show up because they have no symptoms. They show up later. They just don't come in early. And things that can protect you from getting colon cancer, okay? And, unfortunately, the first one is something we tell everybody all the time, is diet and exercise, right? Exercise makes a huge difference. And it doesn't mean you have to exercise till you're exhausted. It just means you have to do some exercise, right? I tell people after dinner, go out and walk for 20 minutes. Go do some simple things, get on a stationary bicycle while you're watching television and stationary bike for 20 minutes while you're doing something. That makes a huge difference. It makes a huge difference. And in particular, I'm just going to jump ahead of something else I was going to point out. In patients who have colon cancer and they're getting treated for colon cancer, studies show now that those patients that continue to try to exercise, if they exercise, besides the chemotherapy, their rate of cure is 20% better than in people who don't exercise while they're getting chemotherapy, right? So that's huge. And when we talk about chemotherapy, a 20% improvement, people think it's like the best drug that's come out. And the simplest thing you can do is exercise while you're doing your treatments. Not again, you don't have to be, exhausting yourself, but if you keep active and you're still doing things, it will improve your success at getting rid of the cancer, okay? So exercise is obviously important. The other things that can help is even a baby aspirin. So surprisingly, people ask me, and a baby aspirin has been shown in a certain percentage of population that have colon cancer to decrease the risk of the colon cancer of growing and also of how quickly it grows. So there's a type of genetic marker in certain types of colon cancer. This was a big study, the Nurses' Health Study, is where they had all these nurses. We're talking like 50,000 nurses, 75,000 nurses, right? We're talking huge numbers of people. And they noticed that in the nurses who had this gene, this particular gene, now we know that they were responsive to aspirin. So if they took a baby aspirin, it decreased their risk of colon cancer, and it improved their survival if they took the aspirin. So it's something pretty simple. Taking a baby aspirin every day or even every other day can actually help your colon cancer, prevent you from having colon cancer, okay? Of course, you do have to take it with a little bit of food or something like that, just so it doesn't bother your stomach. But still, I think it's worth it. And we talk about also not just aspirin, but even non-steroidals. Sometimes the Advil and things like that actually has been shown to even decrease potentially as well. And the other thing is vitamin D. So it's surprisingly, people talk about vitamin D all the time, but vitamin D levels, they're important, right? Even in people with colon cancer, it's important. People who have low levels of vitamin D don't do as well. Their colon cancer, they do worse with their colon cancer, right? So that's something that you can do, right? That's something that you can take. You can just, making sure you're getting vitamin D, and I tell people frequently calcium as well. So usually taking 1,000 milligrams or 1,200 milligrams of calcium, which we tell everybody anyway they should be taking it. Most people don't get enough calcium in their diet because they don't drink milk anymore. They don't eat dairy as much. But you should have about 1,000 to 1,200 milligrams of calcium, okay? So those are some simple things: vitamin D, the aspirin, some exercise that can help your survival and just protect you from getting colon cancer. So the first, you can see, these are some other risk factors for colon cancer. The first-degree relative. So first-degree relative being, obviously parents, brothers, sisters, right? Those are first-degree relatives. So the rate in somebody who has a first-degree relative, if your brother or your sister had it or your parents had it, your chances of getting there are 4 times higher, okay? If you have high cholesterol, it goes up a little bit, 1.6 times higher. If you're overweight, if you're over, especially if your BMI is over, 30, it's 1.5. Alcohol consumption, 1.7. Okay? So those are all risk factors, right? Unfortunately, many people have risk factors nowadays, okay? But these other things, and some of these other things are also risk factors, but they're not the numbers aren't as impressive. Having, kidney disease or having vitamin, D levels are low or being sedentary, they're not as significant, but they still affect things. Let's see. So things that can also, other risk factors I'm just going to mention for people are things like, for example, obviously the family history, like having Crohn's disease, ulcerative colitis, having had radiation in your abdomen. That increases your risk of colon cancer, okay? And cystic fibrosis does as well. These are specific kind of genetic abnormalities that happen. And the reason I put it on here really is so that it kind of hammers the idea that colon cancer, so much of colon cancer is not hereditary, right? It's like the opposite. I think a lot of people think it's hereditary and that's why they don't have to worry about it. But in this, for example, FAP, which is a rare condition, but it only accounts for 1% of colon cancer. People who have FAP, 100% get colon cancer. Every person who has that genetic abnormality, 100% get colon cancer, okay? But they only account for 1% of all the colon cancer in the world, in the country. And Lynch was another one, which is more common. They account for 3%. I mean, these two diseases that doctors talk about all the time only account for 4% of all the colon cancer. The other ones is just, it happens, okay? And again, these other ones as well. These are other, but the bottom line is many people have no family history and they just need to be screened. So when you look at 12% of colorectal patients carry 1 or more mutations. So that's the thing. Many people don't have 2 genes. We all have 2 genes. If you have 1 good gene and 1 bad gene, then many times the good gene will take over, right? But the problem is, now we realize if you have 1 bad gene, it probably increases your risk a little bit, okay? We used to think, well, the good gene would take care of it, but in fact it doesn't. It still increases your risk. Not as high, but it still increases your risk, okay? And 16% of people who are diagnosed early, like I told you, it's because they have some genetic abnormality, but, okay? Let's see. So, this is something I think is kind of interesting. When you look at the benefits of screening people, right, just doing colonoscopies, right? So every 10 years, if you do a colonoscopy every 10 years, it saves about 20 to 24 people's lives out of 1,000, okay? if you do the stool test, just the stool test, just to check for blood in your stool, right? Just that's pretty simple. That's not even doing a colonoscopy. It'll save 20 people out of 1,000 just doing the test to check for blood, because it'll detect microscopic blood that you won't see. Okay? So even if you did that, that would save people's lives. Okay? So I can't stress to you, even if you don't do a colonoscopy, your doctor should be, or you should ask for it. And frankly, honestly, I get so many referrals now, and I ask the patients, and they say, no, my doctor didn't send me. I'm the one who said I need to have a colonoscopy. Okay? So a lot of people tell, I'd say about a third of the patients I see now, they're the ones who said, I asked for the colonoscopy. It wasn't the doctor who told me. Okay? So it makes a huge difference. I'm going to just mention briefly a few other things. I'm going to skip over this. But what it shows is that there's also these other tests, right? So the other tests I kind of want to mention in particular is the Cologuard test. Okay, the test that you do the box, right? It's good to do. It's better than doing nothing, but it's not as good as a colonoscopy. Okay, when they have it on television, the commercials, I think people gloss over that, and including doctors don't do it the right way. Okay, so if you have a history of polyps, the Cologuard isn't valid. Okay. So you can't be like, well, I had polyps, 5 years ago, 10 years ago. I'll just do a Cologuard, and that happens a lot. And then that doesn't pick up whether you get colon cancer again. Okay, so the Cologuard isn't accurate if you've had polyps before. It's not accurate if you have a family history of colon cancer. Okay, it's not accurate if you had Crohn's disease or ulcerative colitis. Okay, it's not accurate if you said you saw blood in your stool. Those are reasons you can't do the Cologuard. You need to have a colonoscopy. Okay, so unfortunately you can't say, well, I'll do the Cologuard, and people do it all the time. They say, well, I'll do the Cologuard, that way I don't have to go through a colonoscopy. And if it comes back negative, you think you're safe. And I've seen people have a positive, negative Cologuard and come in a year later or 2 years later with colon cancer. Okay. Now, it doesn't happen all the time, but it happens often enough, okay? So I don't want you to feel like, okay, I'll just do a Cologuard and then I don't have to do a colonoscopy. Let's see. So in particular, like for example, this is I think it's important. I said we start screening at 50, but now it's 45, right? So the new guidelines are age 45, right? And if you have a family history, if you have, like I said, a brother, sister, so on, or parent, then it's 10 years earlier. So if your family member had it when they were 50, you need to do it when you're 40. If they had it when they were 45, you need to do it when you're 35. Okay? So it's 10 years before that person. Okay? And partly it's because we know that colon cancer grows very slowly, right? Or the polyp grows very slowly. So what happens is you form a polyp, the polyp gets bigger. As it gets bigger, the risk of colon cancer goes up. Okay? So when we find a big polyp, it's because that's been there for 5 years, 8 years, maybe even 10 years almost. Okay? So sometimes people are surprised. When I find a colon cancer, that's probably been there at least 5 or 6 years growing, and you just didn't realize it. Okay? And the problem is, I tell people, if I find it when it's small enough, I can remove it during the colonoscopy, and you don't have to have an operation. Right? So I try to tell people it's worth it because I can save you an operation, or a gastroenterologist can save you an operation without you having to have a major operation and part of your colon removed. Okay? All right. So, but in particular, what I was going to point out is that it depends on the size of the polyp, is what I was saying, right? So if a polyp is 5 millimeters, the colonoscopy detects 75% of those polyps. If you do the stool test for blood, it only detects 7.6% of those polyps. If you do the Cologuard test, it picks up 17% of those polyps, right? So you can compare. If it's a small polyp, you're going to pick up 75% versus 17% with the Cologuard. Okay? Again, if it's a polyp that's over 10 millimeters, it's much better. 95% of colonoscopies will find a polyp over 1 centimeter. The Cologuard will only detect 42%. Okay? So you can see the numbers are, it's 50% less, right, if you do the Cologuard test. Okay? it's better than not doing it all. I mean, if you're going to not do the test and you're only willing to do one test, then it's okay to do it. But I'd prefer you to do the best test, right? Again, by the time somebody has colon cancer, right? Again, the colonoscopy picks up 95%. The Cologuard picks up 92%. Okay, but that's because the colon cancer is big. By then, it's this big. The test is going to be positive with the Cologuard, right? But we don't want to find you when it's this big, right? We want to find it when it's little, because then we can take care of it through the camera, through the scope, or you're just outcome. You don't need chemotherapy then, right? If you do it here, you're going to end up with chemotherapy, right? So the point is, it's better to do it early, and it's better to do the colonoscopy. Okay? Let me see what else. I'm not going to specifically, it kind of just says the same thing that I just talked about. So these are kind of the guidelines we tell people, right? Colonoscopy every 10 years. So it's and I want to point out a couple of brief things. So every 10 years is true if you have no polyps, okay? That's none, right? If you have a polyp, it's not 10 years, okay? It's 5 years. If you have more than 3 polyps, it's less than 5 years, 3 years, okay? So if we look in there and we find half a dozen polyps in you, we're not going to tell you to come back in 5 years. We're going to tell you you have to come back in 3 years, okay? And then some people, I've gone in there and I found 15 polyps, 20 polyps, right? And they have no symptoms. They're shocked. You have 20 polyps, I'm not going to have you come back in 5 years, right? I mean, it's not going to have. So we frequently, in people like that, we'll have them come back in a year to make sure. One, we make sure we don't miss any, because when you remove 20 polyps, we were spending a lot of time doing that colonoscopy, and the reality is when that happens, the rate of missing a polyp is probably about 20% that we're going to miss a polyp, 1 in 5 chance. So again, I don't want you to think it's 10 years, because a lot of patients tell me that all the time. I said, when did you have your colonoscopy? I had it about 10 years ago. What did they find? They found a couple polyps. I said, well, you were supposed to come back 5 years ago, not like now, 10 years later, okay? So again, if you do, there's other things that we do now. We do the blood to the stool test, like I told you. It's better than, it is good, but it's not as good as the colonoscopy. Now some people have been trying to do CAT scans instead of doing colonoscopies. But again, it's not quite as good. You have to do it every 5 years, and if there's any stool, if there's anything like that, they can't tell the difference between stool and a polyp. So you have to get cleaned out. You got to get cleaned out, which is the worst part of the colonoscopy. And then if they find something, you got to come back and do the colonoscopy prep all over again and do it again, right? So you're not saving yourself a lot by doing a CAT scan, because you're going to have to go through the colonoscopy prep twice anyway. And then the old-fashioned, we used to do the sigmoidoscopies, the ones in the office. We did it every 10 years, but that's, like I told you, would only see polyps and cancer on this side. And now we've started to try to do capsule tests, where we have people swallow a capsule and take pictures. Though people sometimes now, more and more people have heard of that capsule test. That capsule test is only really right now for the small intestine and not the colon. Right? We don't use it for the colon, so nobody's doing it for, you can't do a capsule test for a colonoscopy right now. If somebody has a capsule, it's because we're doing it of the small intestine. Let's see. They did a study, and I'm just going to mention this. So they did a study where they looked at people who had the old-fashioned barium enemas, where they put dye in your colon. They did the flexible sigmoidoscopy, where they did a partial test, and they did a colonoscopy. And patients preferred the colonoscopy over the other 2 tests, because both of the other tests, you're awake, right? For the colonoscopy, you fall asleep, right? You're asleep, so you don't feel anything, right? But if you do the barium enema, you have to be awake, and you have to hold the barium in your colon while you're awake, right? So it's like they filled you up with literally almost like several liters of barium, and then you have to hold it and not let it come out, right? So most people are pretty uncomfortable. They pretty much thought that was the worst test. Okay? All right. So again, this kind of shows, like I was trying to say, 1 or 2 polyps, maybe 5 years. 3 or 4 polyps, 3 years. If you have 10 polyps, definitely 3 years. And then it, depends. If we feel like we didn't remove, if we found a big polyp and we're not sure we removed it at all, we recommend you come back in 6 months. Okay? Let's see. What else was I going to say? So the other thing is that now, if the earlier you come in, right, you can have the surgery done laparoscopically, right? You don't have to have it done with a big open scar, right? They can do it through small incision through your belly button, a couple other small scars, and your recovery is faster, you go home faster, and people do well. So, that's another reason that the earlier you come in, the chances are you won't end up with a big scar. You'll only end up with a couple small scars, and your recovery is much less. You don't end up having all the complications and things like that. So you can do it laparoscopically, right? And the one thing we're starting to do now, and this is becoming the really wave of the future now, is gastroenterologists starting to remove pretty big polyps, even tumors in the colon without surgery, right? The procedure can take up to, sometimes 3 or 4 hours. Like it's like doing a colonoscopy for 4 hours, right? So, but we go in and we remove the polyp or the cancer all through inside the colon, right? Not everybody does it. So it's not like you can go to anybody, but certain gastroenterologists do it. But that's because it takes extra training, but it also takes just 3 hours. Or it could take 3 hours or 4 hours. If you do it often, it might take you 2 or 3 hours. But if you don't do it that often, it could take you 4, even 5 hours, right? So most gastroenterologists don't want to do something for 4 hours, right? They'd rather do do 5 colonoscopies than do 1 colonoscopy, okay? But we're really starting to do it endoscopically, where we can remove it through the scope. Let's see, what else? I'm not going to focus on that so much. So the other issue is that I'm just going to mention the chemotherapy from colon cancer is not quite as bad as it used to be. Okay, it's not as bad. Not everybody's hair falls out. They don't get as sick. We can control things, right? So what we do is they remove the polyp or the colon cancer, and we check how many lymph glands are involved, how many lymph glands are around the cancer. Once we see how many, if there are positive lymph glands, then those patients could potentially get colon cancer that'll come back because it ends up in the lymph glands, and we remove the cancer, but the lymph glands still have some, and it grows back. So we realize that those patients that are in between, that they benefit from getting the chemotherapy. Okay? But in people who come in earlier, there's less chance of you having lymph glands involved. Okay? This talks more about how many lymph glands and things like that, and there are other things. Let's see what else. It talks a little bit about survival, but okay. I think the other thing I guess I wanted to briefly talk about separate than this was just a little bit of reflux, acid reflux, okay? Because I think it's so common, right? A lot of people have it. A lot of people have it. I ask everybody who comes in for a colonoscopy if they have reflux, right? And I'd say I'm shocked at how many people say they have reflux, right? So, and the reason I bring it up is because people who have reflux also, if you've had reflux for a long time, right? There's an increased risk of getting cancer of the esophagus, okay? And cancer of the esophagus is becoming the fastest growing cancer in the country, okay? So, and it's because a lot of people get reflux and they kind of don't take it seriously. They take Tums or they take Rolaids, or now it's over the counter, so they take some Pepcid, or they take, Prilosec for, a few days and they feel better and they stop it. Right? And I'm not saying you shouldn't do that sometimes, but if you're having to take the Prilosec over the counter for years, you need to have a test done, right? Or you need to see somebody, right? You can't just blow it off. You really should check. So acid reflux, they get something called Barrett's esophagus, and it's the lining of the esophagus starts to down. And that increases your risk of esophageal cancer, or cancer of the esophagus, right? And it's all because of reflux. And what we're finding is, unfortunately, it is higher in men than women, right? So it is in men. They tend to get cancer of the esophagus much more commonly, okay? They get esophageal cancer, and a lot of men don't even realize they have Barrett's esophagus. We've diagnosed their esophageal cancer, and then they realize they probably had reflux for years and they didn't know it. All right. So there's different symptoms that can come with reflux, and I'm just going to go through a few that I think people don't realize. So one is obviously heartburn, but just because you don't have heartburn doesn't mean you don't have reflux, right? I tell people there's reflux, heartburn's one symptom, nausea is another symptom. If you just have nausea, a lot of nausea in the morning, that can be a sign of reflux. People who have a cough, they have a cough that just doesn't go away. They're just like a cough, cough, cough. Nobody can figure out what the reason for my cough is. That can be reflux, okay? That's a pretty common thing. I see a lot of people with cough, right? And once they go on medicine for their reflux, they're like, this is the first time my cough's been gone in years, okay? So cough is another one, right? Another one is feeling like food gets stuck. Like, you know, a piece of bread, a piece of meat, something gets stuck. That's another sign of reflux, okay? Sometimes also a lot of burping and belching. You don't have heartburn, you don't have acid, but you're burping. You burp all like terrible after you eat sometimes. And then people, you know, they drink a little seltzer water, they drink some caffeinate, some carbonated beverage, and they burp and they feel better. But that's a sign of reflux, okay? So, and the foods that can aggravate reflux, I'm just gonna go over briefly because they're so common and people don't realize. So one is coffee, right? And doesn't mean you can't have a cup of coffee, but I tell people, if you're drinking 2 or 3 cups a day, you want to cut back to 1, okay? If your chocolate's another one. So hot chocolate, candy chocolate, sweet chocolate will cause reflux too, okay? Another thing is, what I tell people is, if you're having chocolate, I don't want you to have a snack of chocolate at 9 o'clock at night and go to bed at 10, right? Which a lot of people do, okay? Okay, and then another thing is onions, raw onions. So in a salad, a sandwich, and a salsa that's chopped up, raw onions will cause reflux, okay? Another thing that people don't realize is peppermint and spearmint. So spearmint gum, peppermint tea, peppermints, people frequently say to me, I thought that was good for you, right? So that can cause reflux. So sometimes you're doing it to yourselves. I see people all the time, I tell people this, and they go, I suck on mints or I chew gum all the time, all day. It helps my, I think, reflux. Okay? So that, another thing is, of course, is alcohol, any alcohol, but in particular, the worst one is red wine. Okay? And of course, the other thing is not to eat too late and lay down, which a lot of people now, they eat dinner and they lay on the couch or they lay in their bed and watch television and they get reflux. So you really, even doing that could help tremendously if you don't do that, if you sit up for 2 hours, okay? So, and there's quite a few, obviously, medicines things, but now I'm just gonna mention to you, we are starting to do things endoscopically to help reverse the reflux, or to stop the reflux. So we're doing things where we're going down with the camera and we're trying to tighten the esophagus without having to have surgery, right? So, and that's becoming a big thing. And in my practice, and we're gonna start doing it probably in the next year or so, we're gonna start doing it more and more because so many people are getting reflux. Okay? All right, I think I'm gonna stop and ask if you guys have any questions about everything I talked about. Thank you, thanks. Any questions or anything?
I think you've answered most of the questions.
Thanks.
The big one that
Thanks.
I had was, if there's a family history,
Yeah.
you should be coming early. And
Yes.
I learned something new today. You should go by the age that they developed it.
Correct.
So that's a very, very important
Right.
tidbit.
Absolutely.
That is really important. So if you have a family member with colon cancer, find out how old they were.
Right.
And I know we do that for breast cancer.
Right.
Because it does help to kind of guide you
When-
how early you should get screened.
Right. And I can't stress enough, let me say, just to reiterate, I forgot to mention, so if you have one single first degree relative, so like I said, parent, brother, sister, but if you have 2 second degree, so second degree would be cousins, aunts, uncles. If you have 2 family members that are like a cousin and an uncle, right, then you're at risk as if you had it was your mother or your brother. Okay, so you need to know. So, and sometimes people think, well, it was my cousin, and then it was my aunt. Then you're at risk. Okay, I'm sorry. Go ahead. Yeah.
I appreciate you taking the time to
Sure.
to walk us through all these and educate us. I was wondering if there are any correlations or patterns with people who have lactose intolerance and other conditions like irritable bowel syndrome or colon cancer. Do you typically see a connection between those?
It's a good question. So with the lactose, definitely there is no correlation. So when you look at, and I'm just going to mention lactose intolerance because it's such a common thing that everybody has. So really in the population, I tell people about 40% of the people have, 40% of people in general have lactose intolerance. So it's pretty high. When you look at certain ethnic groups, for example, I'm Mexican, but Hispanics, it's even higher. It's probably more like 60%. So, and when you look at African Americans or blacks, it's high as well. It's probably closer to more like 60% as well. So you do see it a lot more, but there's no increased risk of like that. Yeah. Okay. And with irritable bowel syndrome, there isn't any increased risk with irritable bowel syndrome. Again, irritable bowel syndrome is so common, but and it's funny though. I do see sometimes people have colon cancer in their family, but they also, some people just have IBS, and I don't know. There's no real correlation though. Yeah, of course. Yeah.
I have a couple of questions here.
Sure.
I have a mother who's 102 years old. She had a colon cancer
Okay.
when she was 72,
Okay.
and I think that she said they moved a foot of her colon.
Mm-hmm.
No radiation, no chemo. So she's 102 years old.
No, that's
Okay.
great.
And my question is, are they still recommending taking aspirin anymore for cancer? Just take an aspirin daily?
I do. I think I said the whole aspirin thing's a little bit controversial because, we were recommending it for heart problems, right? For a lot of people and then people have stopped taking it. I'm mentioning that not from a heart standpoint, but even from a colon cancer standpoint, it is probably helpful. It is helpful. So not just in colon cancer, but other things it's been shown. Probably also, I think I mentioned the whole thing with the reflux and the Barrett's, which is precancerous. If you take things like Advil or aspirin, it increases your risk of esophageal cancer too.
The other question would be, if you have polyps, say every 5 years you have some polyps,
Right.
they remove them,
Right.
and they tell you every 5 years to come back
Right.
to check it.
Yeah.
Can you come back earlier than that?
So,
recommendation?
it's a little tricky. I think what we tell people, I'll be honest, the simple answer is, the insurance doesn't want to pay for it, right? Okay, right? I mean, and I'm going to be honest because we're in a small little group here, and I know you're not going to tell on me, but if you say you have some bleeding, or you have some other symptom, and you have polyps, then we can do it earlier. Right, I'm not suggesting that you do it. Part of it is we used to do it way too much. When I first went into practice, I've been unfortunately been doing this longer than I want to believe. But but my partner, when I first started, I started in '98, he was doing colonoscopies every year. Like every year, if somebody had popped, they'd come back every year for a colonoscopy. And back in the late '90s. Early 2000s, people were doing it every year, 2 years, they were doing colonoscopy on people, right? And that's too much, right? So that's too much because the risk of, anesthesia, the risk of, the procedure, right? And so I think that was too much. I do think, I think 10 years might be too long, right? Because, and people sometimes go, well, I had it done 10 years ago. I say to people, I'm not same person I was 10 years ago. I mean, 10 years ago, I was a different person. And 10 years later, things happen, right? So you can do it earlier, but you really, if you're having symptoms, you should do it. If you're not, if you're okay, then it's okay to wait.
Okay, last question for you. I have one for Dr. Clark later on. Oh, I have another question for Dr. Clark later on. But one other question was,
Sure.
I got my notes here. I can't see.
You can ask me later if you want. That's fine.
Yeah.
Okay.
My question is, how is diet associated with colon cancer?
That's a good
Or
question.
is it associated at all?
So it's a little controversial. I think that it is and isn't. I mean, it's actually been hard to prove that. I mean, we know certain things are simple, right? So if you have what we call ultra processed foods, right? Ultra processed foods, absolutely, they're been associated with colon cancer. So the ultra processed foods are all the stuff that I hate to say that many of us eat, that people, and they don't have breakfast. They just get a muffin that's made, and they get a bagel that's in the bag or something like that. Those foods that are ultra processed, they're definitely been associated with colon cancer. So those things have been associated. Those things but some of the other things, having a high fiber diet is good for you, but we haven't 100% proven that that's prevents you from having colon cancer, right? And we haven't, meat. Having more red meat has been associated with slightly, not as much as we would think, right? We think, if you're having meat, it's going to increase your risk a lot. It probably doesn't increase it a lot, but it does increase it, right? So having certain meats, like in particular, if you have like cured meats, like, some countries, some places, and many, societies, they cure their meat, right? They almost like smoke it or they cure it. Like it's like cured meat has been shown to be increased risk of stomach cancer and colon cancer. Right, so you do have to, it tastes good, but you're having beef jerky is not good for you to get. You can get stomach cancer. Okay, all right, go ahead.
One more question.
Sure.
Okay, we have people who are vegetarians and they go on let's say they're on a vegetarian diet, but they eat a lot of like processed meat, vegetarian meat or something like that. And so if you're a vegetarian, should you eat like just natural food, or
I think
can you eat the processed food as a vegetarian? Like the fake meat, beef.
That's a good question.
You have something called
it's a really
spam
good,
and all that.
No, it's a good question. I think, right. No, that's a good question. I mean, I think all of us know that, if we all ate like our grandparents or our great-grandparents, we'd all be healthier, right? I mean, if we all grew our own, vegetables in our yard and we made them, we ate them, that's probably the best thing, right? But the problem is that now we don't, right? And you're right. It's true. And what I see, what I was going to tell you that I see is a lot of people tell me they're vegetarian, right? But they don't eat much vegetables. They just don't eat meat. They eat pasta, they eat rice, they eat all that stuff, but they don't eat hardly any vegetables. So I have a lot of patients that tell me, I'm a vegetarian, but then they come in and they're either, really overweight, because they became overweight when they became vegetarian. Because now they eat rice and they eat pasta and they don't eat any vegetables, right? So I think if you're eating, pasta that's processed, right, and rice that's processed, then that's probably not as good as if you just had some vegetables that were fresh. Okay? Yeah, go ahead. Yeah.
I'm a witness to some of that. I have a cough.
Okay.
Which I have bad allergies.
Mm-hmm.
And one of the doctors that I've been to said the allergies, when I lay at night, I have to sleep on a lot of pillows. Because when I lay flat,
it drains.
it drips.
Okay,
And
yeah.
then it goes down and it leads to the acid reflux.
Sure.
They start to go down.
Yeah.
And then I cough a lot.
Mm-hmm.
And sometimes my cough starts, I feel the throat tickles. And then after the tickling, then I start coughing.
Yeah.
And mine come in 3 after the coughing, then I start belching. And then so I have this horrible, and it's been going on for years.
Yeah.
And when I do cough sometimes, I don't have a cold.
Right.
But then I cough, and it's like I'm blowing bubbles.
Yeah.
And it's very irritating if I go around. Sometimes I don't want to go anywhere because people hear me coughing, they might think I have something really contagious. But I have to stay put when I start coughing. If I'm here now, I have to run outside because it's not going to stop. And then I get some treatment for it. Some things it's good, and some it's not bad. But that's my constant problem. If I touch my neck, I belch. You know, I mean, I just touch somewhere and I start belching. You know, it's awful. And this, I'll tell you, Doc,
Yeah.
this has been going on for a lot of years.
So it's not uncommon that people have, it's a little hard. When you look at the 3 most common causes of cough for chronic, the order, not meaning this one's more common. It's either it's allergies, right?
Yes,
That's
I have
one.
allergies, yes.
Allergies, it's something called cough variant asthma. So people have asthma, that's just but they manifest their asthma through cough or it's reflux. Those are the 3 most common causes of cough.
Okay.
In people who have chronic cough. So it can sometimes be a combination of the allergy and the reflux both. If you treat one or the other, it just doesn't get better and go away.
Okay, and one more question.
Sure.
I do take sometimes the magnesium, citrate of magnesium. I don't do it all the time.
Yeah.
That thing tastes horrible, but I try to take every so often.
To get
I take
cleaned
a
out.
bottle
Yeah.
of that.
Yeah, we don't
which
want you to
helps.
do it too often. I have
Okay.
other patients who tell me they do that they get cleaned out or flush their system out. But it can cause your potassium to drop. It can affect your magnesium levels, calcium levels. So you don't want to do it too often because it can cause kind of electrolyte problems. Okay? Okay? All right. All right. Thank you. Oh.
Last question on this side here. Okay, I had a flex
Flexibility.
sigmoid. Mm-hmm. Okay, that was some years ago. I supposed to have a colonoscopy, but anyway, so I complained to the doctor. I had it both done. I think maybe both done within the same. I don't know, maybe a couple of months or so.
Okay.
And they did colonoscopy, and then they found some
Polyps? Yeah.
and they removed them.
Good. Yeah, no, it's good that you did it. Like I said, it's not good if the flexible sigmoidoscopy now we know isn't adequate. It's not enough of a test. It's not. You really have to have a full colonoscopy. Okay. All right. Thank you. Thank you. Thanks. Thank you.
If you have any questions for Dr. Clark, you can do so now.
Yeah. We'll take some questions and save the lecture for another time. But do you have any questions about the inflammatory eye disease that we talked about? Any questions? Okay. All right.
I think you didn't discuss this, but if you continue to have eye floaters, how do you get rid of them? They've been in for years and years and years. Someone said within 6 months it should be gone, but years and years, and it's still floating stuff from one eye and went into the next eye now.
So the floaters that I was going to discuss was when you have the uveitis that moves from the front of the eye into the back of the eye. But I'll go ahead and answer your question. So whenever you go out and you talk as an ophthalmologist, somebody wants to know about why do I have floaters. So floaters is, remember I showed you the picture of the eye and I said the middle part of the eye has a gel. As you get older, the gel can degenerate and pieces of it, that's what you see as the floaters. And it's usually a very benign problem. It's not going to bother you. The only time you worry, and we call it a posterior vitreous detachment. If you get a sudden onset of showering of floaters, change in your vision, or if you've been doing something traumatic, that is when you worry. So if you were playing football and you get a blow to the head and you suddenly get floaters, that could be troublesome if it is related to a retinal tear. So that's the time when but the benign posterior vitreous detachment, unfortunately, it's not curable. And over time, It doesn't get better, but you ignore it. You ignore it and you just don't remember you have it. It's worse when you go out in a lighted area because it's a shadow effect. So it looks like a little black string moving around. All right, thank you. No other questions? We'll turn over to Dr. Philippe to close off. You guys have been wonderful today. Thank you.
We would like to thank everyone for participating, for your participation. And Dr. Perez is still here, but it looked like he's answering a phone call because he's still on call. Up to 2:30, it looked like he was still doing procedure. It was a busy day for him. We thank him for coming. So you see Dr. Perez in the back? Oh, okay. All right, so we thank Dr. Clark. You know, that's our, our backbone here. Yeah, so we have two churches, Town and Country and Bethlehem, so we thank Dr. Grace for being all the time here, all the time we need her, she's here for Bethlehem and both Town and Country as well. We have some visitors from other church. We want to acknowledge Dr. Ferris. He's on the phone over there. Nancy, Confidant, and Rachel. Rachel. Okay, she wants me to say it in French. Rachel. All right, so we want to thank Dr. Perez. Dr. Perez, I was telling them that you were in the middle of procedure around 2 o'clock. So God will bless you for that. So God will guide your hand when you're doing the colonoscopy, and we always to make sure that people are better. God is good. All right, so I'm gonna give the mic. Don't forget that we prepare something for you. On the back we had some drinks, some refreshment, and we still have food. That's still warm. If somebody wants a plate to go, you can collect it on the back as well. That's the lunch that we have. So I'm going to turn the mic over to Sister Avia.
Thank you. Members and visitors of Bethlehem, as you all know, today is a very special occasion. We would like to recognize 2 individuals who unwaveringly commitment to the health message and service to others continue to inspire and uplift our church family. On behalf of Bethlehem, Pastor Clark, Dr. Philippe, and the Health Ministry Department, we extend our heartfelt appreciation to Dr. Perez and Dr. Levy Clark for their remarkable devotion to advancing the principles of healthy living. Their timeless effort to promote physical, mental, spiritual wellness reflect the very essence of mission as a church community. We are especially grateful for the time and care they have taken to prepare and administer today's health program. Their dedication to equip us with knowledge and encouraging Christ-centered lifestyle choices is both admirable and deeply appreciated. May God continue to bless their work and ministry, and may their example motivate each of us to live in harmony with God's plan for healthy and wholeness. Now we'll present we have 2 baskets here. The first one that Kyle have is for Dr. Perez. So I want to thank you very much. You're welcome, and thanks for coming. The second one is for Dr. Clark. I think maybe bright. All right, thank you both.
I would like to also thank, I don't know, how do we call them, Pastor? The people who prepare the meal for us. We have a name for it, hospitality. We'd like to thank the members of hospitality. They work hard to make this day possible. I came in here yesterday. It was late. They were still here. Thank you. They know who they are. I don't want to mention names so I don't forget anybody. If I don't forget, if I forget someone, then I'm in trouble. All right, Pastor, give us the last word of blessing so we can get something to drink and eat, and then we can depart. Thank you, everyone, again.
All right. Put your hands together one more time. This time I want to thank the Health Ministry Department. Notice he didn't thank himself, so it's on my shoulder to thank the department being led by Dr. Philippe for making today a special day. We can say that over the years, we have been having some great programs from the Health Ministry Department. What do you say? Yes. All right, thank you very much. And Doc, we just want to appreciate you for your effort, your time, working along with the team and making sure that everything goes well. We appreciate everything that you've done and are doing. And let's put our hands together for Dr. Philippe and his team. Amen. And again, of course, I want to just emphasize the thank you to both doctors that are here today in their presentation. Information well received? Yes. Yes. Information well received, appropriate and to the point. Information that we can use, capitalize on, build on the information that we have, and also to implement. Again, we must implement. If we don't, then what would we say? The time is, well, let me not finish that statement. But let's implement. Amen? Amen. Again, today you learned myself. I'm hearing, but that's okay. The secret is out the bag. One of these days you shall taste, okay? One of these days. With that said, I want to thank you as a congregation for being here today and for making this a reality. Or guests that came with us today, spend the time with us today. We thank you all for coming. And with that said, we are going to stand and close. Or you have something else?
I also want to thank technology and the head of the usher as well. I have help from everywhere. I like to involve everybody. But technology, head of the usher, we have technology, make it happen. All we know that this is the fellowship hall, but we transform it. They transform it, make it available to transmit. Even Zoom, YouTube. Almost every corner wherever you are in the building, you can still see what's going on. Good job, technology. God bless you.
All right. Good job. Let us stand as we pray to close. Heavenly Father, we again praise and adore your holy name because you're great and almighty. We thank you for being the God who cares about us. You sit high on your throne, yet you are in the affairs of men. We thank you for the wisdom and knowledge that you have given these individuals so they can share what you have given them to us so that life can be better. And now, Father, we pray that you will give us the retention and give us the ability to apply the knowledge given to us so we can be healthy. We look forward to the day when you shall come, when there will be no more pain, no more sickness, no more suffering, no more death. We shall live with you forever. But until then, we ask that you be with us, guide us, protect us, for we ask it in Jesus' name. Amen. Thank you, and good evening, everyone.
Don't forget to help yourself. Table are set in the back. You will see an open door in the back. You go yourself.